Can I go straight over to Becky, please?
Thank you.
Over to you, Becky.
And thanks for coming this morning. I'd like to move on to the Community Mental Health Transformation Programme. And I guess my first question is, given that we've now got an ambitious 10-year health plan, are we continuing with the Community Mental Health Framework in its current guise, or will we be seeing changes or even replacements?
Well, the framework's been very helpful in terms of leading us to the place we've got to, actually. I mean, it was published in 2018, I believe. And its focus, as I say, it's been helpful because its focus has been about neighbourhood. So you can see kind of why we've got to where we've got to. I'll ask colleagues about their experience over the years of it and its applicability, but I actually see it as a bit of... Launchpad isn't quite the right word. Basis is kind of a solid base from which we are working, but perhaps...
Sorry, just to be clear on the question now, and I absolutely take your points, Baroness, well made. Just as we've got to now the 2025 point and we've got this 10-year health plan, will we now be continuing with the framework as it is? Will we now be seeing changes and or replacements? So I don't know if Gareth or Caroline perhaps want to talk.
I think it represents, I guess, our understanding of what good looks like in mental health is ever evolving. So we're not departing from the community mental health framework by any means. I don't think we're saying that that's no longer applicable. I think we're moving forward. We're using the learning from the framework and applying that, particularly through the 24/7 pilots as well. But I think my assessment would be that the community mental health framework has taken us a huge way forward since 2018, and there was some very big issues that it was designed to fix, particularly around integration between primary, secondary and inpatient services, more personalised approach, not seeing people as a diagnosis but looking at the totality of their needs. I don't think we've come all the way with all of those things, so we need to move further forwards, but we're definitely not ditching it, as it were.
Great. So, and I absolutely take your point, both of your points about the historical success of this. That's absolutely great, not in question. I suppose now that we are in this place, I just want to be clear that we're going to keep this framework and we're going to see that framework moving forward. There won't be a significant change. Is that right?
Well, the significant change is the testing and hopeful rollout of the 24/7 neighbourhood model. So you take the basis of the framework, which is, you will have picked up from the evidence that you've had already that the application of the framework has varied around the country, and there have been some particularly digital barriers to full integration and full multidisciplinary working at a local level across organisations. But the basic principles of community mental health teams working with the voluntary sector locally, with the local authority sat around the table, with primary care as a key partner, all of those principles go into the new approach in terms of the new neighbourhood model. So it's definitely not a moving away from the content or the principles of the framework.
Great, that's completely clear. Thank you so much. So I suppose my next logical question is that it was, as you say, implemented, I can't remember if it was 2018 or 2019 now, one of the two anyway. And so it's been going for a good few years. And so as all good health professionals, I'm going to ask you about the possibility of an evaluation and whether we will see an evaluation of the framework, if you have plans to undertake that. I think that'd be really useful. Are there plans to undertake an evaluation of what's gone before?
Sorry, I'm hesitating because I'm thinking, in some ways, it's not the exact answer to your question, I freely admit, but our actions since has shown, I think, what our experience has taught us, which is this is the right approach. And it's interesting, I was just looking back, but the framework that was established in 2018 is very much what we're still talking about now, which is a no wrong door approach and a needs-led approach. But as for formal evaluation over the years, there will have been consideration. But again, perhaps Caroline might comment on that.
I think, if I'm correct, there were evaluations. So this started out with pilots, as the 24/7 model is doing, and there was evaluation in those early stages to ensure that it was being implemented in the most effective way. I don't think we have plans for a wholesale formal evaluation at this point. I think what we're looking at is drawing in the evidence about what we know works best, particularly looking at those international models and then through the pilots to think about how this can be best taken forward.
Okay.
And we've been constantly sharing learning throughout the course of the rollout of the framework. So although it was published in 2018, it didn't kick into the long-term plan until 2020. We know what happened in 2020. So it did take 2 or 3 years and it was always part of a 3-year rollout of the framework across the country and the investment that went with it.
Lovely, thank you. So just a sort of gentle challenge, I would say, about valuation, just as, you know, and you've worked in the healthcare system, I'm sure, for a considerable amount of time, and there's always pilots going on and things happening. So at the first evidence session that we had, Rethink Mental Illness reflected on the call for a national evaluation of the framework, which has been given through CQC and others. And they said this is always what holds mental health back. When there is no evaluation, commissioners cannot keep proving to their financial directors that this is what they should be investing in. Then everything falters and stutters, and attention goes elsewhere. So it's just a gentle challenge, perhaps, to think about sort of, you know, doubtless this has been a good framework. Doubtless there's been learnings. I can absolutely hear that, but we have heard during our session that there is a large call for evaluation across various organisations. So that's a gentle challenge back.
And it's a fair and gentle challenge. I think my view is that the question is on evaluation is what will it give us we haven't got already, and are we like just drawing a line now? And actually I think what we're trying to convey, as I know the committee's heard, is a more of a continuum, because there is a downside to going right, line drawn, evaluate, start all over again, which is also a real challenge in government that tends to have been a bit traditional, and I think my feeling in this role is actually this is a mature way forward that we're doing, because we're not dissing a previous framework, we're building on it and getting on with it.
You heard, Baroness, and fully respected, giving you the challenge
It's
from the organisation.
Always fair.
Yeah, and understanding within health that we always have to make the case for allocation of resources. There are limits.
Absolutely right.
For that.
Let me share that view.
Thank you. So just one final thing from me about the implementation of the framework. Again, we've heard from various people during our sessions, including the Royal College of Psychiatrists, and they actually, Gareth, I think you've alluded to this, that they describe the implementation of the framework as patchy at best, but mostly inadequate. Now, you may or may not think that is harsh. I'll leave that to you. But could you perhaps identify very quickly what lessons you've learnt from the implementation to date that enable the vision of this neighbourhood care to become a reality, perhaps to assuage some of those concerns about the implementation of the framework, just in a couple of minutes?
You want to go? Yeah, I think digital and data has definitely played a key role in terms of if you bring people from other organisations in, you have to find ways in which you can collect the information about the service that they're taking and collate it in a way that enables reporting to an understanding of the service, and that has been difficult where you've got an electronic patient record in a provider and getting access from voluntary sector and other partners in to be able to do that. That's undoubtedly been an issue. I think similarly the allocation of key workers across a multidisciplinary team, where the key worker might be someone who isn't part of the close clinical team, I think has been problematic in some teams. But I go back to one of the key things, and I think the Public Accounts Committee identified this as well as the NAO, when they looked at, in quite close detail at the programme. Overall, they considered it to be a well-led and a well-run programme, but they definitely made some recommendations around the routine outcomes collection, which I was talking about earlier on. And I think if you've got that wider concern, Dr. Cooper, that the service without an evaluation isn't able to sort of compete in terms of local decision making, I think the routine collection of outcome information and the building of what it would cost and what it delivers in terms of a local population, I think that's a key mechanism that we can start to get some parity in local decision making. So I don't necessarily agree with the Royal College of Psychiatrists on that point, but obviously they're welcome to the views. I think we've got some examples of really good practice, both in Midlands Partnership across Staffordshire and Shropshire, and in Sheffield Health and Care, of really successful implementation, and it's learning like that we've been sharing with other systems and providers over the last 3 years.
And we do know that there are challenges in implementation. It isn't universal across the country. It'd be quite wrong to say that. And one of the things is good relationships between the key partners is key, and they vary.
No, and I'm sure that people listening will be glad to hear that, and thank you for that. And just one sort of final thought is that Rethink Mental Illness, when they came to see us, they have actually sought to plug what they see as an implementation gap, and they established a dedicated community mental health unit supporting the rollout of the framework in 13 ICS areas across England, which you may or may not know about. So I suppose, again, gentle challenge back is that it's very good that you've acknowledged that, it's not perfect. It can be, it can differ from one area to another. So as you move forward to plug any gaps, I would just ask that you perhaps sort of engage with these organisations who've given their time to this inquiry and provided some valuable information.
We work really closely with Rethink. They provide a massively valuable contribution. I know I've mentioned the Somerset example where they're the lead voluntary sector provider there, and they're just absolutely brilliant. I just also wanted, I guess, just to say in terms of consistency, I think that's a really key theme in the 10-year health plan as well. So as well as the kind of issues that Gareth has described in terms of local improvement and integration, I think a kind of emphasis on transparency and improved outcomes data and the importance of streamlined regulation, I think will all be really important for those things as well.
Sounds like ongoing evaluation to me. So.
We're going to swiftly over to Becky. Becky, over to you.
Thank you, Chair. Hopefully a relatively short question. It's around short-term commissioning cycles, actually. So could you outline how you are going to support, or how you are supporting, integrated care boards to move away from short-term commissioning cycles, which I hope we all agree are fairly damaging for long-term strategic planning across any sort of health service, to multi-year contracts for VCSE organisations supporting the delivery of community mental health services. And then if you could just let us know what guidance has been issued to facilitate this shift, which I'm hopefully anticipating is happening. I don't know who wants to take that.
You do the first bit and I'll do the second bit.
Okay. So yes, absolutely really important point, and particularly I think with the VCS and thinking about those local organisations that are so integral to providing mental health support and supporting the NHS, actually picking up a lot of demand that the NHS isn't able to do so. We absolutely need to support them to be able to plan ahead and maintain a financially sustainable position, and I think that's something that we want to be thinking about as part of the 10-year healthcare delivery plan, in terms of a more sustainable commissioning structure. So not just thinking about mental health, but more broadly in the round. I don't know, Gareth, if you want to say something.
Sorry, Caroline, apologies. Just on the specifics, you're moving to multi-year. I appreciate that ICBs are moving to strategic commissioning, full stop. But you're moving to multi-year commissioning for mental health services, VCS. You're moving to that.
The planning round will require plans from systems in terms of the finance element for 3 years, in terms of the delivery of the 10-year plan, a 5-year plan.
Yeah.
Those local commissioning decisions and contracting decisions will be decisions that continue to be made by ICBs, but you would expect that knowing your allocations as a local system for 3 years in advance does allow for that to be more absolutely.
So just, perhaps playing devil's advocate slightly, and I'm reasonably sure this won't happen, but perhaps you had a rogue ICB that thought, we're going to continue with single year funding, commissioning, perhaps, their books aren't looking terribly good. What recourse would you have to step in and say, actually, single year commissioning, we're not doing that anymore? How does that work?
That would come down to the plans that were being made by ICBs and submitted to regional teams, and the assurance of those plans.
So regional teams could say, we're not signing that off. Thanks very much.
There is still that ability to be able to do that, yeah.
Okay, well, so there's some checks and balances. Hopefully they won't be needed. And so just sort of following on the guidance that's been issued to facilitate this shift, or, how are you supporting the ICBs? Is that part of the broader strategic commissioning shift for ICBs?
It's part of that, but there's also been a recently published planning framework that has gone out to systems and providers. We expect there to be some sort of planning document that goes out to systems and providers. I think at the moment we're expecting early October, date to be confirmed, where the clear expectations about what systems need to be and providers need to be planning for over that 3 to 5 year period will be set out.
Right, that's helpful, thank you. And very quickly, how do you plan to resource the voluntary sector to participate in the development of neighbourhood mental health care, which is probably a very large question, but just a couple of points would be great.
I think it goes back to previous answers in that we know through the community framework investment, which was £900 million over the 3 years of that expansion, significant expansion in community mental health teams. What we saw was local systems and local providers funding voluntary sector partners through that approach and bringing those voluntary sector organisations into the multidisciplinary approach. At the same time, an awful lot of our crisis services are funded through the voluntary sector, provided through the voluntary sector, commissioned by local commissioners. So I think what we would like to see is what we'd see through the 24/7 model would be a continuation of that. Okay. Those existing relationships and existing service models would just be provided in the new way of working. So that would be the plan. From a commissioning perspective, what we are continuing to encourage is local systems like Northamptonshire, for example, who have pulled together a mental health alliance whereby a single provider, in this instance the Mental Health Trust, has the devolved mental health budget local spend devolved to them, for them to then have an alliance arrangement, an agreement with voluntary sector partners and other partners at that local level about how they are going to jointly plan, jointly commit resource and jointly deliver services within that alliance framework. And I think the devolution of local commissioning budgets to groups of providers where there is a partnership with the voluntary sector is something that we want to continue, because I think that mitigates the risk that you talked about earlier on, Dr. Cooper, in terms of the commissioning decisions being made by providers working together.
And I know from talking to lots of local charities that actually that alliance model is very attractive because it enables them to work more collaboratively. Instead of competing for small contracts, they can actually decide who's best placed to deliver what aspect of the total service, which I think is much more effective for them and for the patient, obviously, as well.
Okay. Aspirational. It makes sense. I look forward to seeing it.
But it's happening now in practice. So it's happening in Northamptonshire and has been doing for 3 to 4 years.
It's great, Northamptonshire.
And it's happening elsewhere.
Yeah, elsewhere, yeah, absolutely. And just coming from Sussex, it's definitely patchy. But I look forward to it
Understood. It's a model we want to encourage. We want to encourage.
Okay, thank you.
Thank you very much.